We've done this presentation for 3 or 4 years now, I believe, Vanessa, and it's always good to be able to pull together clients, HFMA members, others, again, in the physician realm, to be able to, again, go over changes that are significant here in 2015 and initiatives that we all need to be aware of in order to be able to stay abreast of activities in Part B billing. I will caution you guys a little bit because we've opened it up this year to all of Region 6 of HFMA, which I believe includes the states of Michigan and maybe states outside of Ohio and Kentucky. As Vanessa goes through a lot of her graphs or statistics, you're going to notice that and forgive us for this, but the reporting on those are going to be specific to CGS and the 2 states of Ohio and Kentucky, not necessarily national information when we look at certain of the statistics she's reporting. But generally speaking, you've got a great national, review of Part B billing. For those of you that have signed up, I'm hoping that you have the PDF. Susan Stokes, who's helped us with Region 6, get us set up here with today's webinar, has, I believe, mailed this out or emailed this out to most of the participants today. But I will say, if you don't have it, you can get on Alta Partners website and download it. With the value of having this PDF is that many of the exhibits that Vanessa's going to go over are hyperlinks. So to have the actual file and be able to click and get to the portion of the website that's relevant to what you're looking for is very, very valuable. Alta Partners website is www.alta, A-L-T-A Partners, P-A-R-T-N-E-R-S, LLC.com. AltaPartnersLLC.com. Again, if you don't have this particular PDF, do download it and again, keep it on your desktop throughout the year. You'll be referring to it frequently, I'm sure. With that, let me pass it over to Vanessa.
Thank you, Stan. Good afternoon, everyone, and thank you again for inviting me back to give you our Medicare update for 2015. As Stan had indicated, the handout is available if you didn't receive it on the website, or you have a copy of it from the registration when you signed up. This handout is very unique, and it basically assists you with so many of the concerns or items that you're looking for regarding the Medicare program. It can be utilized for Part B in addition to certain links for Part A also. And with that being said, I'm going to go ahead and get started. Bear with me a little bit as I go through the slide presentation. As you know, whenever there is any type of Medicare publications that we receive from CMS or as a contractor, we have to identify our disclaimer. This is basically letting you know that when we put this information together, it was accurate at the time. As you are aware, Medicare can make changes or does make changes on a daily basis. So if there has been changes throughout this presentation, I will identify them as we go through. For today's objectives, I will be discussing our new and ongoing Medicare initiatives. I'm going to provide you with information regarding medical review contractors, in addition to our medical review department. I will also provide you with CGS operational reminders. This is information and feedback that we receive from other departments here within CGS. We meet on a monthly basis, and a lot of the feedback that they provide to us, to me, is good information because it will assist in identifying the issues that they're seeing, and we can share that information with you so that it could prevent possible delays in your appeals, redeterminations, medical review requests, in addition to your claims processing. And I'm also going to introduce to you our resources and self-technology options that we have available. On your handout, it is called Real Help for Real Issues. This is a very simple handout packet that we have put together, and we have gone through a lot of our Medicare findings on issues and concerns that providers are having and getting assistance with specifics on Medicare. So hopefully this will be an excellent tool for you to use back into the office. The first thing that we are going to start with is in regards to our new technology. In your handout, you will see several links that are actually live that you can select, and it will assist you in identifying some of our new technology that we have. One would be My CGS Web Portal. Now, the My CGS Web Portal is available for Kentucky and Ohio. It is available for Part A and Part B. We have put together some information regarding what we offer through My CGS Web Portal. This is an excellent tool in, one, having your claims processed electronically. Two, you can check eligibility. In addition, you can look at your financial information regarding what you have pending within our systems. You can retrieve your remittance notices also. Now, with this here information, it is taking you to what we call a PDF form, and it is the actual manual for My CGS. I'll select one, and I'll do the Claims tab. Hopefully it will come up for me. If not, when you upload your handout into your system, it will take you to the PDF. And it is taking me a moment to go there. I'll try another one if it'll go through. It's not letting me bring it up. But if you click on each link in your handout, you will be able to go to the specific page in our hand manual, and it will identify to you the steps you will be taking in submitting an electronic claim. One thing I really like about what we call the Claims tab, it will basically walk you through step by step in how to submit a claim electronically. If you are a specific specialty, there are specific information that you would have to submit. It will identify that on that. For example, if you're a chiropractor and if you follow through on the 1500 claim form, there are certain lines of information that you have to put in. For example, item 19. Or if you have to put information for podiatry services, the date last seen by the attending physician. Also, if you submit Medicare secondary payer claims, and I know everyone has problems in doing this electronically because I think it's kind of intimidating, all of the lines that you have to address. On My CGS, it will give you step-by-step instructions on how to complete your electronic submission for Medicare secondary payer claims. On the next slide, it is a continuance of information that we do have available for you throughout My CGS. This is an excellent eligibility tool, and the eligibility tool will identify to you if your patients are enrolled in traditional Medicare or if they're enrolled in a Medicare Advantage plan. There are so many changes going on with the first part of the year that some of your beneficiaries may have decided to remove themselves from traditional Medicare and have signed up for a Medicare Advantage plan. Please keep in mind that when Medicare enrollees make a change, they have up until around the end of March to go back to another plan. Medicare does provide them with that. So this here will show you if that individual has changed their enrollment status, and it will identify who is their carrier as far as their insurance. In addition, under the eligibility tab, it will identify if Medicare is primary or secondary. It will also identify whether or not the individual could be enrolled in a hospice for a certain amount of time. It will identify that also. So there's a lot of information out here under the eligibility tab. We ask that once you get registered through My CGS, you will have access to all of this information. There's also what we call the admin tab. This is the first tab that you will see when you're registering for My CGS. An admin tab is indicating that that person that is signing up for My CGS will be the authorized user for My CGS. We're allowing 2 admins to sign up. They will have access to all of the information that is through My CGS, and they will appoint to their staff what links they would like for them to be enrolled in. You may not want your staff to know about your financial information, so you would not give them access through that. You may want just for someone working at the front desk to have access to eligibility. So the admin will assign that individual to that specific link. Please keep in mind that each individual that is registered for MyCGS has their own username and own password, and this information is not to be shared. We're giving you information to a very high security database, and you have to follow the regulations that CMS, the Centers for Medicare and Medicaid Services, has set forth for this. We also provide you in this manual a specific link that will take you to the Centers for Medicare and Medicaid Services regarding security on this and the penalties if this database is abused. So it's an excellent tool to have within your workplace, but please remember, you do have to protect PHI. So again, if you want to register, all you have to do is select the link here in your handout, and it will take you and lead you step by step. This is so, one thing we like to throw in all the time, it's free. All you have to do is take a few minutes and sign up. With that being said, we'll go on to the next section. We also have information on why you're contacting us. Our customer service area is quite busy during this time of the year and throughout the year. We receive over 2,000 calls per day, and sometimes there may be a delay in waiting. But here we're providing you with information on some of the issues that we are seeing on the top inquiries. The number one would be coding errors and modifiers. As you can see, within the quarter, we received over 14,000 inquiries. The next is indication not classified. We've received over 12,000. Medicare secondary payer, we received over 10,000 calls, and duplicate billing, over 9,000. Misrouted calls regarding written correspondence, we have received over 6,000. In the box next to this graph, we are also providing you with links that can assist you in addressing some of the questions that you're having or inquiries that we're having. When Medicare is secondary, the primary payer must be billed first, and we do identify that, and we also provide you with our publications that we have available regarding Medicare secondary payer. This is a very helpful tool in addition to MyCGS. Verify patient insurance information against our Medicare secondary payer job aid that we have. This is a PDF file, and it will assist you in what questions that you should be asking your patients or whoever is responsible for that individual. We also want to remind you that through MyCGS, you can get this information. Duplicate services, we have information regarding that also. It is important to avoid submitting a duplicate claim. Please remember that when you're responding to a request regarding additional documentation, also known as what we call an ADR letter, you do not want to submit another claim until a decision has been made from that additional documentation request. If you feel that it has been a long delay in getting a response, please contact our call center so that they can check to see why the delay is going on so long. We also have our information regarding how you can check the status of claims in the handout through MyCGS, or if you would like to go through the what we call interactive voice respond. This is the IVR, where you will have to provide key in information through the IVR to receive that information. Also, we have information in the handout regarding coding errors and modifiers. We have an excellent tool on our website that you can go to, and it will identify every eligible modifier. Now, there may be modifiers in our database that we do not recognize. However, we have retrieved every modifier from the American Medical Association CPT manual, in addition from the what we call the HCPCS modifier. Although those modifiers are listed, it will identify whether or not it is something that Medicare uses, but it will also provide you with a description and instructions on how to use that modifier. One of the top modifiers that we see coming into the CGS systems would be the 59 modifier. Here we are providing you with instructions, and in addition to publications that have come out through what we call our Medicare Learning Network, and specific information on how to utilize the 59. We also have another top modifier would be the 25 modifier. Here we're providing you with information and findings that we have regarding the 25 modifier. It is very important that whenever you are using any specific modifier, your medical records are documented to identify that those modifiers should be applied. If the documentation does not meet the requirements under the modifier, then those modifiers should not be used. Also, not classified where the provider is not certified. Please remember, we are currently going through a national provider revalidation process. This process will continue until March of 2015 unless we hear other information from CMS or directives telling us to continue. But we are anticipating for the first revalidation to be completed by March of 2015. On your handout, under the second bullet, we are also providing you with a web link that you can go directly to the CGS website, and it will provide you with a listing from 2013 all the way up to current 2015 of mailings that we have made to providers where we are requesting for them to complete their revalidation. The revalidation process provides instructions that you can only revalidate once you have been notified. You have 60 days to get that information into our provider enrollment department. If everything is correct within your application, you will receive a notification that you have passed your revalidation. In addition, if we are finding that something needs to be changed or added based on your status of your practice or group location information, we will identify that to you either in writing or via email. But it is very important that you follow the instructions, and please make sure that when you're doing your revalidation application, even though you are not involved in the credentialing, but if you are going to be contacting us to check the status of an application or the status of your revalidation process, your name has to be listed on that 855, electronically or the paper application. If your name is not listed, we will not release any information to you. We will only speak with individuals that are listed on the 855 as a contact person. But we do have all of that information in addition to training tools available on our website. We always ask that if you have received a remittance notice or an electronic remittance advice notification indicating that the provider was not certified at the time the services were being rendered, your first step would be to go out to the CGS website, and you would bring up the revalidation listing, and then once you bring up that file, you would select the type of practice that you're in. It can be for Part A, hospitals or organizations, home health and hospice. There's a tab out there for that. It could be for Part B groups or Part B individual providers. All you would have to do is go to the specific one that you're listed under, key in do a Control F, key in your NPI, and if your name is or NPI is listed in that chart, that means that you did not respond to that revalidation. We get a lot of calls, a lot of emails that providers have been deactivated. And once they are deactivated, we will not process the claims. They are immediately denied. So it is very important to make sure that that information is coming through and you do respond to those letters. In addition to the revalidation process, if you pass the 120 days from responding to that revalidation, you are deactivated and you will receive a new Medicare enrollment and effective date if you pass that 120 days. If you fall under 120 days but past 60 days, Then once we get that 855 in, we will go ahead and do your revalidation, and your records will remain the same. In any way, though, if you pass the 60 days that we are providing for you, you are deactivated, and there will be a delay in the processing of your claims. We do not go back and reopen claims. Once your information has been updated and you have a new number, or your number has been reinstated, you will have to submit the new claims. So it's very important to pay attention to these notifications that we mail out. Misrouted calls or written correspondence is also, again, a high number, and we are providing you with information on how to get direct contact to those specific departments. But please remember that we have mailing address information in addition to phone number information on our website. We also have information regarding coding errors and modifiers, and we're showing here for you a continuous on the duplicate information. This here is our top rejections that we have, and just to point out, here are the numbers that are listed here, and this is a high number, and this information and data was gathered before January 1 of 2015. So if you look at the beneficiary health insurance claim number, and this is the beneficiary's Medicare number, we have over 700,000 that have been rejected because either the number and the number and name did not match up correctly. Please make sure that you're putting the information either in your electronic or in your paper claim forms exactly what is listed on the red, white, and blue Medicare card. If there's typo errors on the red, white, and blue Medicare card, the beneficiary or their legal guardian will have to contact Social Security Administration and make sure that information is updated. Otherwise, please list exactly as it is written on the from the Medicare card. The Medicare cards are red, white, and blue. We also have information regarding missing and incomplete invalid procedure codes. Please remember that we are currently using right now the new 2015 CPT codes, and as always, some may change or some may stay the same as they were in 2014. But if there has been a change in the CPT procedure codes, you will have to use the one for the current year. We also have missing and invalid practice information. That is also quite high as far as where the locations where the services were rendered. Incomplete, invalid explanation of benefits is also a high number, and then referral absence or exceeded over the 149,000. So we do have a couple of facts for you and identifying how many claims are actually processed throughout the Medicare program. Here we have information, again, non-covered by the contractor. You do want to check for your jurisdiction listing, and this is very helpful if you are providing supplies or material that can be reimbursed through Medicare. You can check this list here, and it will identify if it should go to your DME contractor or if it should be coming to CGS. It will be identified by the carrier. Also, you want to verify the patient coverage prior to submitting your claims. You want to obtain all copies of your patient's insurance cards. Once you receive that information, please check My CGS. Again, an excellent tool to identify who should be billed first, traditional Medicare, Medicare Advantage plans, or if they are even enrolled in the Medicare program. This information is available to you through My CGS, or you can use the interactive voice response, also known as the IVR. We also have non-covered charges. This is information that we have pulled regarding services that are submitted for reporting purposes only. Now, please remember that we're providing here an example of PQRS. This is the Physician Quality Reporting System. When you're submitting this information, it has to come in with a service that will be reimbursed. It cannot come in by itself on a claim or electronic submission. So we're providing you with instructions there. Medicare secondary payer, again, we have a lot of references and job aids available throughout our website for that information. Here we're looking at our top denials. And these are, again, payment issues and claim denials is also identified. And we're providing you with some tips. Our duplicate services, quite high in number. I always like to say, put a dollar amount on that number that is showing there, and that's a lot of money that is being misused because it's a duplicate service. It could be like services that you're billing correctly. However, maybe you left off a modifier to identify that it's not a duplicate. Or maybe you didn't keep up with some information that was published. One example would be changes with the correct coding initiative. In addition, changes with medically unlikely edits that we have released publications on, and those could also cause for duplicate denials. Or you submitted you responded to what we call the additional documentation request, and you haven't provided us enough time to complete that review so that we can release your services for reimbursement. We always ask that you check that information first. And again, we have the what we call the non-covered by this contractor, quite high in numbers. We also have provider not certified. This goes back to the revalidation of services. Non-covered charges, which are PQRS, very high number, and then the Medicare secondary payer. So quite a few denials that are coming through based on our quarterly reviews. Here's information to assist you, what I just went over as far as the physician quality reporting. In addition to our informal review, we have step-by-step guidance for requesting an informal review regarding payment adjustments for your PQRS information. A lot of you have received a letter. Letters went out in November identifying that you were subject to the payment adjustment. Here, that letter identifies, it's about a 10-page notification that you received. On page 3 of that notification, it did identify that if you disagree with that, you would have to request a review. And you had from January up until February to submit that review. So there is information here for you regarding that. We also have information regarding the value-based modifier. Major changes are going on with that right now also. It started January of 2015 and it will run through the 2017. When the value-based modifier information first went out in October of 2013, providers with group practices with more than 100 plus eligible professionals had to register for the value-based modifier reporting. They had to register by October of 2013. For 2014, we have providers that are up 99 and below group practices. They have to register by October of 2014. And starting in 2016, we will then go to individual providers and smaller group practices. So again, a lot of information is listed here regarding that. The number one thing is the payment adjustments. Please, if you received a notification regarding payment adjustment for 2015 and you disagree with it, you have until February 28th to request that review. And the instructions are listed on your letters. The help desk number is listed here also for PQRS, and they are very helpful. They will walk you through the process and assist you in identifying specific answers to your questions that you may have. Okay, here are a couple of urgent issues that we want to bring to your attention also. I had talked about the physician quality reporting initiative, but we also have the electronic health record incentive program. And again, payment adjustments started in 2015 for those that did not meet the meaningful use requirements. Reviews are going on currently also. If you received a letter regarding the fact that you will be going through the payment adjustment for 2015 and you disagree with that, from that one-page letter that you received, at the bottom of that page, there is a link, web link that you will go to, and that web link will walk you through instructions for you to request your appeal. But there are changes regarding electronic health record information. We're providing you with a direct link to all of the information that CMS has posted on their website with step-by-step instructions. Please remember that a lot of individuals who are Medicare providers, and they may not be physicians or what I would say MDs or DOs, there are others that still have to register for PQRS or electronic health record reporting. Right now, you are reporting on both. I know in the past when we had the ESMD, the PQRS, and the EHR, you could either do the prescription reporting or the EHR. The prescription reporting has been pulled over to the EHR, so there are two mandatory reportings that you do have to do, PQRS and electronic health records. These are no longer voluntary reporting incentives. They are now mandated. So we do provide you with information regarding that. We also have our ICD-10 implementation guide here. We are asking that if you haven't tested already, you can go to our website and register to test, and you will be notified by our EDI department, and they will set you up for a date that you can submit claims using ICD-10 diagnosis codes. It has been extended. We are looking at the implementation date as being October 1 of 2015. We have not received any notification that there will be a delay, so everything is in course as of right now that it will go into effect October 1 of 2015. But we're providing you with links to take you out to the CMS website that will provide you with a lot of training material and material on how to get started so that you will have a smooth transition from ICD-9 to ICD-10 reporting. So again, but the main thing is take a moment, go out to the CGS website and register to test your claims, or check with your clearinghouses or your software companies to see if they have already tested. We also have information here regarding the provider revalidation process. This is additional information that will assist you in following some of the training tools that we have available on our website. So again, I know I went over in detail about the revalidation processing for Medicare, for the Medicare program, but there's additional information out here on our website, a lot of training tools and tools that will be able to assist with some of your questions or concerns. We also have information here regarding our 2015 Medicare Part B premiums and deductibles. As you can see, for Part B, the premiums and deductibles have not changed. They are the same as 2014. The Part B premium is $104.90, and the Part B deductibles for 2015 are $147. Please also remember that we process and apply the deductible based on the claim that's coming in. So whatever claim comes in first, if the services do require for it to go to be applied to the deductible, then that's when we will apply it to the deductible. So not all services are applied to the deductible, so there may be some claims that you submitted and you will show full reimbursement by the Medicare program. I would also like to point out information regarding specific modifiers for distinct procedures. Here we are looking at where normally you would be using the 59 modifier on services pertaining to the Correct Coding Initiative. Starting January 1 of 2015, CMS has provided instructions for all contractors to identify that there are some services that will not be allowed with the 59 modifier, but they would be using the HCPCS modifier instead. And as you can see, we are providing you with the new modifiers when the 59 is not to be used, the XE, XS, XP, and XU. Please remember you have to follow the guidelines and you will have to follow the instructions that are listed there. Your first step would be going to the Correct Coding Initiative website, also identified on CMS, CCI, and once you're there, it will identify whether or not that 59 modifier should be used. Before you apply the 59, you should come back to this article, and it's identified as 8863, and then read the description. And if your service falls under that description, then instead of you using a 59, you would use one of the HCPCS modifiers that is listed there. Okay? Also, we have information regarding the chronic care management, CCM services, that go into effect January 1 of 2015. So their information is listed here also. Okay. One thing that we are getting a lot of questions on, and that's the medically unlikely edits. A lot of times you are submitting services in that the units feel exceeds the maximum amount that has been set up for that particular procedure code. The first thing that you would have to do, and this is also going through the CCI website on CMS, and we provide you with that website link that is listed there. You will have to go out, bring up that site, bring up the Excel file to check to see if your code is listed. If your code is listed on this site in the Excel file, it will identify what the maximum units field can be allowed for. If you exceed that, your service will be denied, and in some cases, all services on that specific claim will be denied. You will have to request an appeal, and you will have to provide supporting documentation. If the supporting documentation can be accepted, then we will allow based on what the medically unlikely edits are set up for. If we cannot allow that service, you will be notified, and you have an opportunity to go to the second level appeals. One thing I do want to point out to you is that once you're on this website out at CMS, you will it will identify the contractor that has the copyright for the CPT codes and HCPCS codes. We do recommend that you do contact them and let them know your medical necessity reasoning for exceeding the information that is listed there. You're not sending in patients' medical records, but you're sending in your medical evidence to show that the units field should be exceeded than what is currently listed. They will review that, and if it is within changing, then they will notify us for the next quarterly update. For Correct Coding Initiative and medically unlikely edits, this information is updated on a quarterly basis. Please keep in mind also that not all CPT codes or HCPCS codes are listed under the medically unlikely edits, and if they're not listed on this website, we cannot release that information to you. We can only process the claim based on the current guidelines. We also have information regarding access to telehealth services. As you can see, there have been additional services that will be allowed under telehealth. We have the annual wellness visits. In addition to psychoanalysis, psychotherapy, and prolonged evaluation and management services. For a complete listing of services that are allowed through telehealth, we are providing you with the web link that is listed there. We also have modifications to coverage for the pneumococcal vaccinations, and this did go into effect for services on or after September the 19th of 2014, and in addition to services after February 2nd of 2015. Some of you may receive denials on some of the flu vaccine codes. This happened, I believe it was around October and November. We are currently in the process of making those adjustments. We had to wait until after everything had been updated within our systems before we could go in and make those mass adjustments. So if you haven't received your reimbursement based on the publications that we have sent out in end of November and December, your adjustment will be made. You do not have to submit in a new claim. Okay. This is our compliance quarter, and basically those of you who have been with the Medicare program for a while, you do understand that we have several auditors that are required to request your documentation. The first one would be the Comprehensive Error Rate Testing Contractor, and they are set up to review services that we have processed and either denied, made payment on, or it could be where we even rejected a service. They do go into our system on a monthly basis, and they pull out about 200 claims that we have actually processed and made a decision on. And this is for all contractors. It is just not for CGS. We're listing some of the findings that we have received errors on, and the findings that we have listed here are the ones that we have high error rates on. No documentation, insufficient documentation, medically unnecessary, incorrect coding, and then a couple of other things also. Earlier in the presentation, I talked about the duplicate payment, payment on non-covered services, the high numbers that we have for those services coming in, and several of these we have received errors on. No documentation. This is where the provider does not reply to the CERT request for records. You have up to 75 days to submit that documentation to the CERT contractor. Insufficient documentation. The medical records do not include the pertinent information to make a decision on whether or not we should have allowed or denied your service. Medically unnecessary. This is clinical review finds documentation to be unsupportive of services that were billed. These are services that were unnecessary, or this documentation did not support what was actually rendered. Incorrect coding. The service does not meet the requirements for the level of code that was submitted. So there's quite a bit of information here that we provide, and we just released our CERT findings were just released in 2014 for reporting period 2012 to 2013. Our error rates are still high. Here we're providing you with our CERT errors that were charged by specialty, and this is for the fiscal year 2013. These are the top 10 areas that received errors from the CERT contractor. And as you can see, we are jurisdiction 15, Kentucky and Ohio. We rank one of the top 10. We really need to get these error rates down. We do provide a lot of information on our website in addition to the CMS website on making sure that you understand what information should be noted in the patient's records. We don't always ask for your supporting documentation. That's your responsibility to have that supporting documentation in that patient's record. If you're rendering a service to a Medicare beneficiary, then it's your responsibility to make sure that that documentation matches up with the CPT or the HCPCS code that you're submitting in for reimbursement. And it is also important that when we request for your documentation, be it the CERT contractor, the recovery auditor, or CGS itself, that information should be submitted as quickly and promptly as possible. In addition, all complete documentation should be submitted. In identifying some of our top errors that we have had, and this is statistics based on CGS, and here we're giving you identifying some of the specialties that contributed to our high error rate. Insufficient documentation errors. We're providing you with a direct link to the CGS website, but in looking at the graph here, you can see cardiac surgery was the high one, diagnostic radiology, hematology, oncology, independent clinical lab, also osteopathic surgery. So please remember, be sure documentation accurately describes the service bill. Include copies of signed orders. Verify signatures are valid, legible, and or present. We also, if your signatures are not meeting the current guidelines, we provide an attestation statement on our website that can be completed by the author of the documentation, and it can be submitted in along with your supporting documentation. On the next one, avoid no documentation errors. Remember I said this is where the provider is not responding. Internal medicine, 100%. That's quite high. Respond to all requests completely. Remember, you have 75 days to have that documentation returned. Always remember to include a copy of the bar-coded page that was submitted to you along with your request. Avoid medically unnecessary errors, and as you can see here, we have chiropractic specialties. Then we have independent clinical labs, family practice, internal medicine. Please remember you have to include all relevant medical records, identify the reasons for the surgeries or diagnostic tests that are performed. Always remember that we have local coverage determinations and national coverage determinations. You want to verify medical necessity is being met, and we have that information available to you. We have over 80 plus local coverage determinations on specific services. So you should be referencing our website in addition to the national coverage determinations. One thing I do want to point out, and it's very important, for independent clinical labs, please remember, if you're submitting a requisition form to a laboratory identifying what tests you want provided through that sample, you're not submitting the medical records. You're just giving a requisition form. That requisition form should be signed either electronically or handwritten by the one ordering the services. Okay? If it is not signed, then you should be attaching an attestation statement along with that. Okay? When we request information from the clinical lab, the lab does not have the patient's medical records. So if it's not signed, then that is not, it's found to be unnecessary testing. In addition, avoid incorrect coding. We're providing you with information on evaluation and management documentation guidelines. We're still using the 95 and 97 guidelines. Every once in a while, you should be doing some type of audit on your medical records for all services, and especially for E&M services. Internal medicine is contributing to our high error, family practice, emergency medicine, psychiatry, in addition to cardiology. So please remember that the documentation should be following those guidelines. We also want to remind you of what we have. Another auditor would be the recovery audit program. And this is where the auditor will be requesting either overpayments or documentation on services that we have paid for, and they have found that there's an error or there could be an error in our reimbursement for that service. So it is very important that you review their issues site, and it's CGI Federal Inc., and their site is listed here in the second column here. Clicking on that will take you directly to their website. You can select either complex reviews that they have done or automated. This is where they basically have set up an overpayment because they have found that we have paid services incorrectly. But there is information that is available for you here. And again, you have 45 days to respond to the recovery auditor's request for documentation. The cert contractor is 75, recovery auditor is 45. There's a lot of information out here regarding their current statistics that they have, in addition to where they are getting their information on how to select what services they should be looking at. One thing that the recovery auditor does follow very closely is the CERT program, in addition to the OIG program. They look to see what findings the OIG has regarding Medicare contractors, and there they make their decisions on if they should pursue in setting up a review or an overpayment based on that once it's approved by CMS. And again, we're just giving you a couple of notes here. If no response to their request, then it is set up for an immediate overpayment. Also, please remember that if you have received a notification for an overpayment from the recovery auditor, you can request an appeal if you disagree with the outcome of the recovery auditor's review. But please make note that that has to be identified in your appeal, that this is based on a overpayment request from a recovery auditor. Those are expedited. If it's not identified, then we will proceed with the adjustment, and you will be notified at a later date if it's in your favor to be paid for that service. Here are a couple of reminders and tips, and this is, I call it good feedback from other departments. Our financial department just wants to remind you that you can set up an e-offset through MyCGS, and an e-offset is basically where you're asking us to do an immediate take-back. You have received a notification that a refund is due back to Medicare. You can go through MyCGS and request the immediate offset. Immediate offset is where we would just take the money from an upcoming payment, and instead of you sending us a check. You can also notify us if you want to do a voluntary overpayment refund. We just ask that when you're requesting for a voluntary overpayment refund, you're being very specific and to the penny in identifying what the refund is, voluntary refund is for. We also have information regarding completing redeterminations requests, and that also can be provided through MyCGS. But we are asking that when you are setting up or requesting a redetermination, it is actually a redetermination and not a reopening. So many times we're getting redeterminations when it should be going to a reopening. In addition, we get a lot of reopenings that should be going to a redetermination. Keep in mind, a reopening is a simple error. You want to apply a modifier, and once that modifier is applied, there's no other coverage information needed. Or if you're changing a diagnosis, or if you're changing information that is simple. A redetermination is something where you're supplying additional documentation in order for us to consider reimbursement for that service. We also have MyCGS password help. Very important information. We have changed the time frame from 30 days to 60 days. So every 60 days your password will expire and you will have to do a new one. So please keep in mind too that you to help with creating and maintaining your strong passwords, you do want to use MyCGS Quick Reference. Okay. We also have, as I've spoken before, the reopenings information. You want to make sure that when you're submitting in a reopening request, by phone, by handwritten, or through my CGS, it is something that you're making that change, and that claim is then going to go ahead and go to process for reimbursement. Also for medical review, please remember that on occasion, local coverage determinations are updated, and we usually do this on a quarterly basis, but sometimes it could be each month that we send out our bulletin. You want to make sure that you check the local coverage determinations to make sure that you are following all guidelines regarding that. In addition, when you go out to the cgsmedicare.com website, on the left-hand side, if you select medical review, you can see our action log. I spoke earlier where you should be doing some type of audit within your medical records. I'm not saying auditing everything, but at least randomly selecting 1 or 2 audits per month or per quarter, whatever way that you can. But you can also follow our action log for medical review to see what is currently being reviewed, what is pending. And that would be an excellent tool to follow to make sure that you have your supporting documentation. You never know. We may request your documentation. So you want to fall within the guidelines for Medicare to make sure that your documentation is complete and accurate. And just also, these are some frequently used web pages that are located on the CMS website. I had talked about correct coding initiative. I had talked about what we call our MLN MedLearn articles available for you. Change requests, these are memorandums and transmittals that CMS has set up. When you see an MLN, it breaks it down to be a little bit more user-friendly, but a change request is what your contractor will follow exactly. Coordination of benefits information is there. We have glossaries. We have our health plans, our internet-only manuals. A lot of times you want to know how we look at services as far as identifying who should be rendering those services. If we follow, the IOM in addition to other publications also. The Medicare Physician Fee Schedule database, and the very important tool, it identifies the indicators that are available. And also provider enrollment and information is also available there. So again, excellent tool to have, and we also provide you with our customer service phone numbers and our IVR phone numbers that are available. And it does continue on to the next page. But again, a very handy handout, very simple to use. 13 pages, not using front and back, but it is an excellent tool to have it within your office. I know that it's 1 o'clock, but I'm still available, and if Stan and everyone doesn't mind, I don't mind opening up the lines for questions.
That sounds good. And again, thank you very much, Vanessa, for the presentation.
Thank you.
If anybody has a question, I would ask that you type it into the question box again in the webinar, as opposed to opening it up for audio, which will create some confusion. And again, give Vanessa a chance to be able to read it and answer. If there were any questions offline, Vanessa, what's the best way to either get a hold of you or to find a good resource within CGS to be able to address a question directly?
You can either call into the call center to have your question addressed. I always say that please take that approach first in contacting our customer service representatives. The toll-free number is listed on the previous page, on the last page here, that toll-free number. If you feel that you've reached out to our call center and you're not getting any assistance or you're getting inconsistent information, you can reach out to myself, Vanessa, V-A-N-E-S-S-A, .Williams at cgsadmin.com. Please keep in mind that there are some questions or assistance that you may ask me. I will forward to our medical directors. I will review it, and if I feel that it is something that I should escalate to our medical directors, then I will do that, or to the appropriate clinical staff, instead of taking the chance and giving you inconsistent information. So, and I will let you know if you send me an email asking a question. If I have to forward it, I will identify to the department where I'm forwarding it to you. So, and ask that you give us a little bit more time to get the answer for you. If it does go to our medical director will reply and copy me on it. And it may take them a couple of days to get that information to me. Okay?
Good deal. Well, again, we're not seeing any questions being typed up at this time, so let's close out this webinar here this afternoon. Again, if you haven't already, please jump on, and if you don't have this PDF that was just reviewed by Vanessa, please feel free to jump on altapartnersllc.com, our website, and from that you'll be able to take a download. The hyperlinks is the power within this presentation to get you directly to information and answers to questions that you may have, again, amongst the whole Medicare Part B spectrum of changes here in 2015. Again, I do want to thank Susan Stokes for helping to host this on behalf of Region 6 of the HFMA. And Vanessa, thank you once again for participating and helping us with this educational seminar.
Thanks.
I think that'll wrap it up, everybody.
Someone was someone getting ready to ask something?
Stan?
Yes.
There is a question in the question box.
Okay, then I'm not seeing it. Go ahead. Vanessa, can you see the question?
Did it go to one person?
Let me read it here. So, remittance advices with denial, COB 15 on the evaluation, and management codes along with the Pulse OX. Does a modifier, whoops, it's going too fast, sorry. Does a modifier 25 need to be on these claims?
Okay, I apologize, but I'm going to have to answer that as generically. If we're denying the evaluation and management service, and that service is submitted with additional charges, if we're indicating that the evaluation and management is bundled into those charges, first you will have to check the Correct Coding Initiative website to see whether or not the 25 can be added. If it indicates a one indicator on that Excel file, yes, you can use the 25. However, you also have to have supporting documentation in the patient's medical record to identify that it is a separate identifiable service. So first, check the CCI website, bring up the Excel file. Once you locate your code and it does identify that an E&M is bundled in, go to the far right side, last column, you'll see a 1 or a 0. If it's a 0 there, you can never apply a modifier. If it's a 1 there, as long as you have your supporting documentation, you can apply the 25. Please keep in mind, we do review this sometimes, and just to let everyone know, in 2013, we did do a review. We did a random selection of about 300 claims. And from that review, we came out with a 98% error rate that the 25 modifier should not have been used. And that's on our website, and it was issued out, I'm sorry, I said 2013, I think it was February 2012. So please be very careful in using that 25 modifier. If your documentation doesn't support it, then no, you cannot use a 25 and you cannot submit that charge. But if you have supporting documentation, you can.
Okay, I have one more question.
Okay.
Can you hear me? Okay. I have a question about the 59 modifier. I thought we could not use it anymore. Instead, he had to use the new X modifiers.
Okay, good question. The 59 modifier is still a valid modifier for the Correct Coding Initiative. The new modifiers that went into effect starting January 1 of 2015 are only for the specific indications along with that modifier. And if you look at the guidelines for the, I believe it was XS, XE, and XO modifier, it identifies when you would use that modifier. So if you're getting ready to use a 59 and you read the 3 new modifiers and it identifies that you should be using that letter modifier, then you would use that instead of the 59. But you have to check them first to see whether or not that modifier would be acceptable for the reason of that service being billed. If it's not one of those categories, then you will continue to use your 59.
Okay, that's all the questions I have in the question box at this time. So.
Okay. And just as a reminder, the 59 modifier, the new modifiers that came out and went into effect, I believe in the reference in your handout, it does identify the change request or the MLN article that was published for that. And I want to say it was 8853, MM 8853, but it was on the page. I'm going back through. I apologize. I'm not going to bring back up the slide, but I think it fell under the urgent items, issues requiring your attention, and okay. On page 8 of your handout, at the top of the page, it identifies the 59 modifier, and then it also identifies the new HCPCS modifiers that went into effect. You have to read the description. So if your code meets the description, then yes, you will use that modifier, one of the new modifiers. But if not, you will still follow the guidelines for the 5925. Okay? Thanks, Susan.
Oh, you're welcome. All right. Well, if there isn't any more questions, then thank you, Vanessa.
Thank you.
A lot of great
Thank
information
you.
today.
Okay. Thanks, everyone.
Okay. Have a good day.